and welcome to this webinar. I'm Vallerie McLaughlin from the University of Michigan, and I'm joined by my colleague, Dr. Victor Moles. Victor, thanks so much for joining me.
Hi, Val. Thank you so much for having me here. This is it's a great opportunity to discuss some new topics about pulmonary hypertension.
Yeah, so Victor, I'm so excited to be here. We're here for Team Phenomenal Hope. They're doing this webinar series, and Team Phenomenal Hope is a nonprofit organization dedicated to supporting the PH community. And what they've asked us to do today is talk a little bit about some of the new treatments for pulmonary hypertension. So Victor, I thought that maybe I could just go through some slides with some data, and then we could answer some questions that patients might be interested in. Is that okay with you?
That sounds great. There's a lot to go over, and I'm excited that you showed us a little bit of this information.
Yeah, absolutely. So, we're so lucky to have more than a dozen FDA-approved therapies for pulmonary hypertension. When I first started many, many moons ago, we only had one therapy working on the prostacyclin pathway, and now we have many therapies. And the historical pathways that we've had for many, many years are the endothelin pathway, and we have 3 different oral agents that can attack this pathway that have been proven to be effective in improving patients' symptoms in pulmonary hypertension, preventing clinical worsening. So a very effective pathway. We have the nitric oxide pathway, and there are 3 oral agents here that work in 2 different ways. There's 2 phosphodiesterase type 5 inhibitors, and there's 1 SGC stimulator. So that's another oral therapy, and we often use those 2 oral therapies together. And then there's the prostacyclin pathway, the very first pathway that we had. And there are many therapies in this pathway that are delivered intravenously, subcutaneously, intermittent inhaled, as well as oral. So we've shown a figure like this for nearly 2 decades. We've been able to target these 3 pathways for nearly 2 decades, and we're so excited to now have another pathway as well. Before I go into the new pathway, I want to review a little bit of data on Opsynvi. So Opsynvi was FDA approved last month, and this medication is a fixed dose combination. So both macitentan 10 milligrams and tadalafil 40 milligrams are in this same pill. And we both know that both of those therapies are effective. They've been studied in combination before. For example, all the patients in the Triton study got both macitentan and tadalafil. But the ADUE study, which is what led to the FDA approval of this fixed dose combination, demonstrated a greater reduction in the pulmonary vascular resistance. So that heart cath number that kind of is the big picture reflection of both pressure and flow. So a greater reduction in pulmonary vascular resistance with the combination pill than with either macitentan alone or tadalafil alone. And the safety and tolerability, so how patients handled the medication, side effects, how safe it was similar to the individual therapies. So we now have this as an option for patients who are on both an ERA, endothelin receptor antagonist, and PDE5 inhibitor. So we'll talk a little bit about that, Victor, when we get to the questions, but let's just also go over the new therapy, the new mechanism of action that we have, and this is the sotatercept medication, or Winrevair, that got approved in March as well. So we know there are many different abnormalities in pulmonary hypertension, and we know that the vessels tend to overgrow. And basically, there's an imbalance in your body telling the vessels to not grow as much or get rid of the cells that are really not doing what they should or getting old. This is what we call apoptosis is the fancy word. Balancing that with the proliferation, the growing the cells. So in pulmonary arterial hypertension, there's a balance of that. And the BMPR2 is kind of what is anti-proliferative and what there's not enough of. And then the activin is what there's too much of, and that's pro-proliferative, and that tells the cells to grow. And so there's too many cells that grow, and that's what contributes to the vessels narrowing. And what this new therapy does is try to rebalance that by essentially binding the activin and reducing the activity of that pathway. So there's more balance between the things that are making your cells grow and the things that are keeping your cells from growing or getting rid of old cells. So it actually works in a totally different way than anything we have at all. And what led to the FDA approval of this therapy is the phase 3 STELLAR study. Victor was the PI of STELLAR at Michigan. He put a large number of patients in the trial, and so he has a lot of experience with this medication already. So phase 3 trials are really the trials that help get medications FDA approved. They tend to look at endpoints which are meaningful to the patients, what the FDA considers, feels, functions, and survives. So this study looked at patients who were already on pulmonary arterial hypertension therapy, which is really important because we have so many therapies. And of course, we want to use the proven therapies in our patients. And then we tend to study new therapies in patients who still have symptoms despite being on the proven therapies. So this looked at group 1, specifically group 1 PAH patients who still had symptoms, functional class 2 and 3 symptoms. So they had symptoms of shortness of breath, but they were not the sickest of the sick patients. They were adult patients. They had to have pulmonary hypertension at baseline, even despite the treatment. Their pulmonary vascular resistance, which is that heart cath number that takes into account pressure and flow, had to be greater than 400 dynes. And their hall walk had to be between 150 and 500 meters. And they had to be stable on their background therapy. And any of the background therapies, including combination therapy, was allowed into the trial. The patients were randomized. So randomly, half of them got assigned to receive placebo and with their additional therapy or with their background therapy, and half of them were assigned to receive sotatercept, starting at a 0.3 milligram per kilogram dose and then titrating up to 0.7 milligrams per kilogram. And this medication is given as a shot, an under the skin shot, very similar to insulin, every 3 weeks. So that's how the randomization and the treatment occurred. And then the primary endpoint of the trial, so what the trial was really looking at, was the 6-minute hall walk distance at 24 weeks. And there were a number of very important secondary endpoints, including the multi-component improvement, which looked at functional class hall walk, and biomarkers, the blood test, the NT-proBNP that looks at stretch on the heart, other hemodynamics like the pulmonary vascular resistance. It also looked at what we consider to be a very important measure, time to clinical worsening. Like, does your pulmonary hypertension get worse? Are you hospitalized? Does your hall walk go down and you need additional therapy? Also looked at the French risk score. And very importantly, I think to patients, looked at quality of life. And there is an FDA validated or an instrument for quality of life that was developed with FDA guidance, the PAH SYMPACT, that was used at week 24. Now, I think that's something that's really important in this trial is that this is what we call a highly prevalent population. So these patients had disease for a really long time, 8-9 years. So these are patients who've been living with pulmonary hypertension for a very, very long time. The majority of the patients were idiopathic, what we call idiopathic pulmonary arterial hypertension. Probably a little bit more heritable or genetic-based pulmonary hypertension than we've seen in other trials, and probably a little less connective tissue disease, scleroderma, than we've seen in other trials. Almost balanced between functional class 2 and 3, so that's the severity of the symptoms, and what we call a highly pretreated group. These patients were on lots of medications. In fact, about 60% were on 3 medications, so a medication from all 3 pathways, and about 40% were on pump medications, a parenteral prostacyclin, either sub-Q or IV. They had a hall walk of about 400 meters going in. So a relatively sick population, but pre-treated population, prevalent population. So what we see in clinic every single day. And this is the primary endpoint of the trial, the 6-minute hall walk, and that improved by about 40 meters in the patients taking sotatercept versus the patients taking placebo. And that's what we call statistically significant. So the statistics to tell us if that's a real difference or not showed that it was a real difference, but it's also something that's clinically significant. We have lots of papers that have shown us a difference of about 33 meters is something that's clinically significant to a patient. So it's both statistically significant and clinically significant. And in addition to that, first, that primary endpoint being positive, 8 of the 9 secondary endpoints were positive. So when I see this in a trial, it really is reinforcing that the medication is an effective medication. So improvements in the other parameters like the multi-component endpoint, the pulmonary vascular resistance, the biomarkers, that time to clinical worsening, and 2 of the 3 domains of the quality of life. So the physical impacts, the cardiopulmonary impact were both improved. The one that wasn't was the cognitive or the emotional impact. So this is what I would refer to as a really, really strongly positive study. Now, there's no free lunch, right? Every time we look at a new medication, we also have to think about the side effects. And there are some important side effects to discuss with sotatercept. There was a higher incidence of bleeding events in the patients that had sotatercept. So most of the time it was minor, like nosebleeds, but some of those bleeding events were serious. There was a higher likelihood of them developing those telangiectasias, or those like little red dots on the skin. And then some lab abnormalities. The hemoglobin can go up. The platelet count can go down. The platelets are what help clot the blood. A little bit more high blood pressure in the treatment group. So really important things that we need to consider. So to sum up sotatercept, we're all really excited about it. It's a new mechanism of action. It may help us remodel the vessels. It was a highly positive clinical trial with an improvement in that primary endpoint, but many of the secondary endpoints, including the one that I consider to be very important, the time to clinical worsening endpoint, pretty well tolerated, but there are some side effects that we need to keep an eye out for, including the bleeding risk. And there's some lab monitoring that is required, the hemoglobin and the platelet count prior to the first 5 doses. But overall, it's really exciting to have a new therapy. So I think that's kind of a high level of some of the clinical trial results. Victor, before we go on to the questions, maybe let me ask you what your impressions are from both of those studies.
Yeah, Val. So this is this is really exciting. I think that patients with pulmonary arterial hypertension needed more options to treat their disease. I think that Opsynvi is a very convenient medication for patients with pulmonary hypertension. Just to remind patients that this is not a new therapy, but it's a combination of 2 medications that we had available. Patients who have pulmonary arterial hypertension sometimes take many medications, and being able to consolidate them in one is something that will, I think, add to the convenience and hopefully for some patients to the adherence of the treatment. We also need to remember that patients with pulmonary hypertension can have other medical conditions, and they also may need to take medications for them. So anything that we can do to improve that adherence, I'm really excited about. I had a question for you, Val. Most of the times when we clinically start tadalafil or macitentan, We start them a little bit of some time apart. How are you going to counsel patients who are going to take two medications in one pill if they have side effects?
Yeah, and I think that what I would do in my practice is I wouldn't use Opsynvi right off the bat in a newly diagnosed patient for the reason that you just mentioned. Like when I start patients on dual therapy, what I basically say is, we talk about the two different therapies, I prescribe both of them, and everything needs to go through a prior authorization. So I generally tell the patient to take whichever one they get first, whichever one gets authorized first, take that. And then no matter when you get the second one, wait about a week to start taking that. Because if they have side effects, I want to know which one is causing it. So I think what I would do with Opsynvi is offer that to patients who are already on macitentan 10 and tadalafil 40 and tolerating it well, to improve compliance, like you said, to have one less copay as well. The patients have copays for all their medications. And so having one copay is better than having two copays. So I think that's how I would plan to use it in clinical practice. Let me ask you also, like, what happens if you have a patient who is on tadalafil and a different ERA or sildenafil and macitentan? How are you going to approach a conversation about Opsynvi in those patients?
Yeah, I think that's a great point. I'll just emphasize that the two main points that we just discussed. One is convenience, taking less pills but the same amount of medications. The other thing is chatting with them about their copay and see if we can simplify that for them. If they're taking a different ERA, I may ask them if they had side effects before. So there are some patients who, when they start an ERA, they may have some fluid retention, for example. And if they didn't, I would feel a little bit more comfortable starting Opsynvi right away, rather than starting macitentan and seeing how they tolerate it, and then switching to Opsynvi. If they tell me that they struggle with side effects in the past, like, for example, fluid retention, I may be a little bit more cautious. And of course, there's always a discussion, and we make a shared decision with patients, and then we decide what is more convenient for each patient.
Yeah, so I think these are all great points. So I think for patients who are currently being treated on therapies, if they're on both an ERA and a PDE5, I think it's perfectly reasonable to bring it up with your doctor and say, is this something that might be appropriate for me, might help me reduce my pill burden, my copays. I think the other thing to keep in mind that it always takes a little while for insurance to get drugs on their formulary. I suspect at some point most insurances will cover it, but sometimes they don't cover it right away.
Absolutely.
Yeah, maybe let's move to sotatercept or Winrevair. You had a lot of experience with this in the clinical trial. Why don't we start with you just telling me a little bit about what your experience has been so far?
Yeah, again, I am gonna repeat this one more time. I'm really excited that we have another novel medical therapy to treat patients with pulmonary arterial hypertension. We know that patients do very well in the long term if we can make them feel better, if we can make their NT-proBNP become the lowest possible, if I make their risk scores to be as low as possible. And the truth is that there's a lot of pulmonary arterial hypertension patients that still don't reach that low risk. And I think that that's going to be where patients are going to benefit the most. One thing that I find very impressive is all the endpoints that were met in the clinical trial. I think that the efficacy of this drug has been clearly demonstrated. I'm very excited about the way of administering this drug. I think that there's something that has to do with convenience, with compliance. It's an injection that you have to get under your skin once every 3 weeks. There are some lab monitoring that need to occur before that dosing, but there's no need for daily medications or multiple times a day dosing. So I think that that's something good for the patient. And for patients who are taking multiple medications for PAH, I think that we're always talking about side effects, and sotatercept does have side effects. We don't need to disregard that. But I think that the side effect and efficacy profile is pretty good. And you mentioned some of those side effects. The bleeding is increased in patients who take sotatercept. The development of telangiectasias, those are those red spots in your skin that can occur. We don't really know what that means, if that's something that is deleterious for the patient, if that's something that is good because the medication is working well enough. So that's something that we will have to learn, and those are some of the uncertainties. And you mentioned dizziness and an increase in blood pressure. I think that those side effect profiles are good, and I think that the efficacy is really important for the patients.
So Victor, I mean, I know we're all excited. It's the newest therapy. It's, we haven't had a new mechanism of action in many, many years. Do you really think this is different? Do you really think it's a breakthrough for our patients?
I think it is. And, I think, first of all, we're going to learn more because there's other clinical trials that are studying sotatercept in different populations. So we're going to keep learning about this medication as we move forward. But I think that there's a very large population of patients that, despite all our best efforts, still don't get to where they need to be. And I think the fact that this is a different mechanism of action, the concept of working on the idea of wall remodeling rather than just vasoconstriction, I think it's very encouraging, and we're looking at the disease from a different perspective. And I think that that's important in how we continue to improve the life of patients with PAH.
Yeah, so I absolutely agree with you. I think it's also really important to remind everyone, to really reinforce that this study was in group 1 PAH. So the patients with clear-cut pulmonary arterial hypertension, but without lung disease, without other major causes, without thromboembolic disease. So it's really for the clear-cut group 1. There's a study going on in patients with combined pre and post capillary pulmonary hypertension. You want to just mention that?
Yeah, that's a great point. As I was mentioning before, sotatercept is currently being studied in some groups of patients with PAH, but also in patients who have pulmonary hypertension associated with left heart disease or heart failure with preserved ejection fraction, who have congestion, but on top of that, they have an elevated pulmonary vascular resistance. That study is still enrolling. I think that there is some excitement because this medication may potentially, depending on the results of the study, of course, may be applicable for a larger populations of patients with pulmonary hypertension. But I think that we'll continue to learn more and more about this medication as we gather more information.
Now, Victor, the study, the clinical trial, like the average amount of time the patient had pulmonary arterial hypertension was around 9 years, which is a long time. What do you think about its use in patients who have had, more recently diagnosed disease? What's going to be your approach to that? And maybe you can share a little bit about some clinical trials as well.
Absolutely. So, what we know about sotatercept nowadays, and what led to the FDA approving this medication, is what we know from the STELLAR clinical trial. And you mentioned in a great length who those patients were. I think when we are using sotatercept, especially in the early stages, we had to try to follow what the clinical trial STELLAR showed. And when I'm approaching the treatment of, for example, of a newly diagnosed patient with PAH, I think that using medications that have been known to improve the disease first, it's important. So what we call stabilizing the patient, get them to feel better right away. There's going to be a lot of data on sotatercept early on. There's a clinical trial called Hyperion, and that study is looking at using sotatercept in patients who were diagnosed within the first year of their since their right heart catheterization. And we'll have to see, Val. I think that, as you mentioned, that the effects of the medications are clear. I think we're all hopeful that the trial will be positive, and we'll have to see.
Yeah. So what I think those are all great points, Victor. What I would just add from my perspective is, we have very clear guidelines for newly diagnosed patients based on lots of literature, right? So the newly diagnosed patients who are really super sick need parenteral therapy, need IV or sub-Q therapy, often with other therapies, other oral therapies as well. The patients who are not the sickest of the sick, so the majority of the rest of the patients get dual oral therapy with an ERA and PDE5. And there's lots of literature behind those therapies. They're well tolerated. So I think for the brand new diagnosed patient, that's still how we're going to treat them. But one of the important points of treating patients is, as you said earlier, trying to get them to low risk. So if they're on those therapies and you reevaluate them at 3 or 4 months and they're not low risk, I think that having a discussion, as you said, shared decision making about sotatercept is appropriate. You don't have to wait 9 years, but I think it's going to be earlier in the treatment paradigm for many patients, but I don't think it's going to be initial therapy because we don't have studies to support that right now, and we do have studies to support how good some of these other therapies are for brand new diagnosis. I think the other question, Victor, that's on a lot of patients' minds is, can someone come off their pump if they start sotatercept? So how would you answer that?
I think that's a great question, and I think it's a question that it's already come up in clinic. So I think I would answer that question. I would counsel patients who are thinking about that is that not every patient has the same PAH. Okay, and sotatercept is another medication that we're adding to our treatment options. So for somebody who has relatively mild pulmonary hypertension and they're doing well and they are in a very, very low dose of a parenteral prostacyclin, I think that there is a possibility that sotatercept would improve the pulmonary hypertension to a point that they may come off their parenteral prostacyclin. But if a patient has very advanced hemodynamics, if the right heart catheterization has features like a very elevated pulmonary vascular resistance or a very low cardiac output, I think it would be unlikely that the addition of sotatercept may lead to the pump being replaced. I think, Val, we also know that not every patient responds exactly the same to sotatercept. So these are very, very individualized scenarios. So that's how I would go and counsel patients about this question.
Yeah, so I think those are all great points, Victor. What I also would tell a patient is it's not how it was studied in the clinical trials, right? Like, it's really important to go through the literature that, go through the trials that led to the FDA approval. That wasn't the point of the trial, that patients, that was not the goal of the trial. But I agree that there may be some patients who've had a really remarkable response, are on a low dose, are doing really well, and maybe it's possible. But I would also advise patients to really have that conversation with their doctors. That this should be done by a very experienced PH physician with really close monitoring. Victor, we're talking a little bit about how sotatercept or Winrevair might be different, that it may cause remodeling as opposed to working on the vasoconstriction that the other therapies do. Can you just explain to the audience, what vasoconstriction and vasodilatation is, and how some of those therapies primarily work on that, versus what remodeling is.
Yes, absolutely. So what we've learned about PAH is that there are multiple things happening in the very small vessels of the arteries of the lungs. And those vessels, they have different layers. And there's three main layers. The one in the middle is called the media. And that is a muscle layer. And what usually happens in patients with PAH is that there is a phenomenon of vasoconstriction, which means that the arteries get very tight. But over time, that constriction gets another phenomenon, which is the thickness, the increased thickness of that layer. And the thicker that layer becomes, the smaller the vessel diameter is, the smaller the place where from where the blood can go through. So, and medications that have been approved until recently have traditionally focused or work primarily on vasoconstriction. So what they've done is they help the muscles relax, but that layer may continue to be very thick. When we talk about remodeling, and what we think sotatercept does is it reverses that thickness of the pulmonary vasculature and allows the blood to flow more easily through the pulmonary vessels.
That was a great explanation. And these things can be complementary too. Let's talk a little bit about the practical issues. Like, I know patients want to know, how do I get this? Can I get this? What are insurance companies doing with it? And, I think we go through this every single time we have a new therapy, that sometimes insurance companies take a little bit of time, and it's a little bit of a challenge at the beginning. And I think, Victor, I will share with the audience, in our practice, we've had both ends of the spectrum. We've had a couple of patients get approved right away, actually with a $0 copay. And we've had another patient whose insurance company, a commercial insurance company, say, we haven't reviewed this yet, don't call us, we'll call you, sort of thing, and just totally denied it. So we've had the entire spectrum. So I don't think I can give a specific answer to patients about insurance, but I think it's going to be a process. And obviously it's going to need a prior authorization, and your doctor's office is going to work with you on that. So I think that's the insurance question. I think the other question I want to highlight, Victor, is the safety monitoring. And I think it's just really important to highlight to the patients. You want to go through what's required in terms of blood tests, particularly as you start this therapy.
Yes, absolutely. So the FDA has given some clear guidance on how to monitor, especially for the first few doses. This medication, for example, should not be started in patients who have very high hemoglobin, or shouldn't be started in patients who have very low platelets. And before each dosing, we should be monitoring what is called a complete blood count, when we look at hemoglobin and platelets. And we have some safety parameters. Before each dose, for the first 5 doses, we're going to have to monitor a CBC. And we'll be looking at that hemoglobin and those platelet numbers very carefully. What sotatercept can do, and that's why we're monitoring, is it can make your hemoglobin go even higher, or it can make your platelets go even lower. And that's, what we're going to have to be looking. The FDA suggests that we do that for at least the very first 5 doses, but there are going to be some patients who have very high hemoglobin or borderline hemoglobins or low platelets, where we may elect to do that for a longer period of time. And then it's going to be up to the prescribing physician to decide how often thereafter that's being monitored.
Yeah, I think that was great. And it's important to keep those safety things in mind. And this therapy is going to be delivered with the assistance of a specialty pharmacy and home nursing. And, they would generally teach the patients how to administer their medications themselves, 1 or 2 visits. But the long-term expectation is that the patient would learn how to give themselves the shot. Again, very much like a diabetic gives themselves insulin. So those pieces are all in place to help get the therapy to the patients. So, Victor, I think this has been a great discussion. I hope the patients that watch this find it useful. We talked a little bit about the data with Opsynvi, which is the combination of macitentan 10 and tadalafil 40, and how that might be some appropriate for some patients who are on dual oral therapy. And then we talked about sotatercept, Winrevair, which is a new mechanism of action, an activin signaling inhibitor that's given by a subcutaneous under the skin shot every 3 weeks, and in clinical trials demonstrated improved fall walk and many other endpoints on top of therapy already. Of course, there are side effects with every therapy, and every patient is individualized. And so while we hope this information is useful to people who watch this, it's really important to talk about your own case with your own doctor to determine if these therapies are right for you. So, Victor, thank you for joining me. I will speak for both of us. We're happy to support Team Phenomenal Hope, which does such great stuff, and we're excited that new therapies are available. So thanks so much, Victor.
Thank you so much, Val, and thank you to Team Phenomenal Hope for inviting us.